we're really excited to have Dr. Mellad Khoshnood present today. Dr. Khoshnood began his education at Cal State University Northridge, where he got a BA in biology. He went to the Louisville School of Medicine for his MD degree, and then did a child neurology residency at Children's Hospital Los Angeles. He also, while he was at Children's Hospital Los Angeles, did a fellowship in pediatric neuroimmunology and multiple sclerosis. And he's been very involved in several research projects as well as leadership. A couple of his really interesting leadership experiences, he was the chair of the CHLA Program Evaluation Subcommittee on Family-Centered Rounds. And he also worked on a project called Project Equality, which worked with LGBT center representatives and helped implement the nation's first fully integrated LGBT healthcare education into medical school curriculum. His research has spanned looking at inflammatory markers in SARS-CoV-2 pediatric patients with Down syndrome, and looking at HIV blood product contamination in a worldwide global perspective. So really has done a lot of really amazing things. Today he's going to be presenting about Down syndrome regression disorder, presentation, symptoms, and treatments, and we're really excited to welcome Dr. Mellad Khoshnood.
Hey there, everybody. So as he said, I'm Dr. Khoshnood. I'm a new child neurologist here at Cottage Hospital, working alongside Dr. Cruz. And on top of my fellowship in pediatric neuroinflammatory and multiple sclerosis disorders, I kind of unofficially ended up doing a fellowship as well in Down syndrome, as well as Down syndrome regression disorder. My mentor, Dr. Jonathan Santoro, was kind of the one who spearheaded and kind of described and characterized this condition. And so I was kind of hoping to just go through all the new findings regarding this condition, because it's pretty interesting to say the least. So the outline for this presentation is kind of going over what is trisomy 21, autoimmunity related to trisomy 21, developmental expectations, what the typical causes of regression are in persons with Down syndrome, how that differs from typical symptoms of Down syndrome regression disorder, as well as the typical neurodiagnostic abnormalities and those implications for therapy. So what is Down syndrome? It's a genetic disorder characterized by triplicate of chromosome 21. Obviously, we all know that. It's got an incidence of about 1 in every 1,000 births in the United States. So it's quite a common genetic condition, despite how we kind of quintessentially think of it as a rare condition. Despite all of the medical complications that I will shortly talk about, the age expectancy is dramatically increased over the last couple of decades to now expecting patients to live into their 60s. Despite the consistency of physical traits, there can be some variability in the overall symptoms and complications related to individuals with Down syndrome. The vast majority being full trisomy 21. There's a smaller percentage of patients that can have a translocation mutation or mosaicism, where not 100% of their cells actually have the triplicate of chromosome 21. That's less than 10% of all cases, though, the majority being true triplicate of chromosome 21, hence the consistency of phenotypic features. In regards to those phenotypic features, typically the things that we see, I've got this kind of medicalized, over-medicalized version on the left-hand side here. I really prefer the right-hand side one, because that much more adequately describes the adorableness of our patients with Down syndrome, especially when they're babies. But some of their phenotypic features: almond-shaped eyes with thickened epicampal folds, small low-set ears, malformation of the eustachian tubes, single palmar crease on the palms, macroglossia or large tongue, as well as microsomia and microcephaly. I'll kind of make a plug here. The CDC has recommendations regarding unique growth charts and growth parameters for persons with Down syndrome. So in case you're ever wondering, why is my patient with Down syndrome not gaining any weight in their newborn period despite eating, go find their unique growth chart on the CDC's website, and it'll kind of probably explain a little bit better why that is. Now, obviously, some of these physical features are obvious when a patient is born with Down syndrome if they're not already prenatally diagnosed, but part of the reason it's so important to know about these diagnoses as soon as possible, or at least shortly after birth, because here are some of the issues that can be present amongst persons with Down syndrome at birth. This is not an exhaustive list, but these are just the things that I came up with in a single stream of thought writing out this presentation. So things that can happen to infants with Down syndrome early on include dysphagia, breathing problems that can be both obstructive sleep apnea and central sleep apnea. They are also prone to frequent infections, even in the newborn period, GI dysfunction that can include GER and motility issues, congenital heart diseases that range from things as quote-unquote benign as ventricular septal defect to something as significant as tetralogy of Fallot or transposition of the great vessels. They're also prone to epilepsy in this time period, hypothyroidism, ocular phenomenon, including congenital nystagmus and even strabismus or esophorias, and transient myeloproliferative disorders. Now, take it individually, one at a time, and think of a person who doesn't have Down syndrome. Any patient with one of these conditions, you would think, oh, I'm going to keep an extra eye on this child's development because they're going to be at risk for developmental delays. Now, transpose multiple of these conditions at once, and you can kind of see how we're already setting things up for being prone to things related to developmental disability and delays. Small side note on transient myeloproliferative disorder, this is kind of a unique leukemoid reaction in infants with Down syndrome. While it's pretty self-limited, quote unquote, these persons who have it are at higher risk of developing leukemia later on in life, so just a small plug for that. Now, if only that were the only time period where we would have some complication related to Down syndrome, but even though we're getting really good at helping children with Down syndrome survive and thrive after these conditions shortly after birth, there's also some other things that can happen as they get older into childhood and adolescence. That includes things like celiac disease, acquired hypothyroidism, so even if you weren't born hypothyroid, you can develop it over time, leukemia, as well as obviously treatment-related complications from leukemia, epileptic encephalopathies, type 1 diabetes, arthritis, vasculitis, and uniquely Moya-Moya syndrome, notably more common in persons with Down syndrome. Now, take note of all of the notable autoinflammatory or at least pro-inflammatory diseases that we see here on this left-hand side. But I also wanted to kind of draw some attention to a couple of other things here. So persons with Down syndrome at birth typically are microsomic. So they're small. They often will be described as failure to thrive patients where they have issues with eating and gaining weight and things like that. As they get older into their adolescence, though, they tend to go towards the obese side. And that tends to be because they have persistence of their short stature, and so there's just less places to distribute all of that adiposity. And as a result of being overweight/obese, they're at risk for metabolic syndromes. And of course, not to mention the refractive defects of their eyes. So even if they're not born with ocular phenomenon, they can develop a number of ocular phenomena, including strabismus that can often be multiply surgical refractory. They can also be at risk for hearing deficits, may in part be due to frequent infections, may in part be to atypical formation of the eustachian tube, but all of this, again, sets one up for developmental delays. So what is the typical developmental course for persons with Down syndrome? Global developmental delays are actually quite ubiquitous. It's kind of the rule and not the exception to have global developmental delay in a person with Down syndrome. The range is completely and highly dependent upon the medical comorbidities, access to services, and the phenotypic variability. So we talked again about all of those different conditions that can lead to a person having developmental delay without Down syndrome, and then we sort of compound that effect in persons with Down syndrome because they will often have multiple of these conditions. Now, you're probably going to think, all right, hold on, who's this neurologist who hasn't talked about one of the most mainstay clinical features of persons with Down syndrome? And I'll talk a little bit now about their brain formation. So typically persons with Down syndrome, and this has kind of been elucidated more over the last few decades, have atypical formations of their brain as well as an overall reduction of the number of neurons that they have in total. This often leads to a notable clinical phenotype of significant hypotonia. This can be both an axial and appendicular hypotonia, and if you ever want a textbook example of things like the scarf sign, significant head lag on pull to sit, or things like that, find a patient with Down syndrome and just kind of see what their tone feels like. That's a classic example of it. They can have variability in the degree of hypotonia, and that variability of hypotonia can sometimes be a predictor of their gross motor and fine motor developmental delays. And of course, because every muscle is hypotonic in a person with Down syndrome, that includes our speech centers, that includes our mouth muscles, that includes our ability to feed and grow and things like that. Now, a big question, because I already mentioned that there's some reduction of overall brain size and brain volume in persons with Down syndrome. Is this just built in? So there are some differences in brain development, and I just wanted to cite one paper that talked about difference in volumetric sizes among persons with Down syndrome. So this chart on my left, on the left-hand side over here, there's an x-axis that just talks about the ages, so it's between typically 5 years of age and 15 years of age in this study, and the y-axis is basically standard deviations. The further away from zero they are, the smaller their brain is relative to neurotypical individuals that were used as controls. The closer to zero, the closer it was in terms of volumetric sizes. So when you're looking at kiddos with Down syndrome, you can already see that at default, so to speak, frontal, temporal, parietal, and occipital gray matter was notably smaller in volume compared to the neurotypical population. While they were typically able to catch up to some degree in terms of brain size, overall, they still had a reduced number of neurons, gray matter size and volume of the central nervous system compared to our neurotypical counterparts. This means that there's less interconnections between the hemispheres, less chance for concrete development of skills and cognitive function, and just overall a higher incidence of developmental disabilities long term, likely in part because of this. There's one particular structure, because everyone's thinking, well, hold on a second, you're saying it's smaller in size, but we've all looked at brains of individuals with Down syndrome. It looks like it fills the skull cavity, and in fact it does. Part of it is because they have microcephaly. But there's one notable structure that is considerably smaller when you obtain MRIs of the brain in persons with Down syndrome, and that's the cerebellum. This structure being kind of like an older, what we considered as a primitive one, only being involved with things like posture and, for a finger nose testing and things like that, we've kind of found over the years is much more integral to things like cognitive mapping, planning, muscle movements, coordinations, language skills, sentence structure, and things like that. It's also notably related to your tone. So we found that persons with Down syndrome who have smaller volumes of their cerebellum are more likely to have more significant hypotonia, whether that's appendicular, axial, or both. So now that I've talked a little bit about some of the clinical phenotypes that lead to features of developmental delay in persons with Down syndrome, I wanted to talk a little bit about immune dysregulations in persons with Down syndrome. We all know that persons with Down syndrome are at a higher risk of frequent infections, including things like ear infections and things like that. But I also tried to highlight earlier, as I was talking about all of the different conditions associated with Down syndrome, the higher risk of autoinflammatory diseases. We think that's because when you look at chromosome 21, there are multiple interferon receptor genes encoded. And thus, when you have an extra chromosome 21 spitting out more proteins and products and things like that, what you see is an upregulation of interferon receptors and proteins in the inflammatory milieu. Clinically, this can manifest as a higher rate of autoimmune diseases, increased infections, and of course neurologic conditions. For those who have memorized all the interferons, you can see on that left-hand side a huge list of all of the different interferons and receptors and how many of them are upregulated. We can talk about that later if you'd like to, but that's far outside the scope of this conversation. Just kind of proving the point, there is a higher incidence of inflammatory dysregulation in persons with Down syndrome. What does this look like clinically when you kind of look at patients? Well, obviously we know that they have a higher risk of leukemia. We know they have a higher risk of autoimmune conditions. What's interesting is they have a lower risk of solid tumors. In fact, it's still on the order of case reports and small case series in terms of what the solid tumor prevalence is amongst persons with Down syndrome. And when we look at the overall immune system milieu, like the breakup of cells, what you can see here is what is decreased in persons with Down syndrome are your kind of earlier stage immune cells. So we're talking classic monocytes, naive cytotoxic T cells, immature B cells. What's more upregulated are fibrocytes, inflammatory monocytes, activated NK and cytotoxic T cells, and plasmablasts. All that to say that their immune system is overactive, hence the higher risk of autoimmunity and potential dysregulation. So I paint a very gloomy picture. I'm classically a pessimist, but I try to sprinkle in some optimism as well. It's not all doom and gloom. Life expectancy is up, quality of life is up, developmental outcomes are up. I used up because of the motif. Developmental outcomes are better. So what does that mean? So life expectancy back in the 1950s for persons with Down syndrome was fairly abysmal. Their general life expectancy was an average of 9 years of age before something catastrophic would occur. Now, again, as we talked about over the last few decades, partly because of aggressive medical advancement and better access to services and care, life expectancy is now expected to be in the 50s and 60s for most persons with Down syndrome without severe complications. Quality of life is up as well. Part of that is we no longer institutionalize persons who have chronic medical conditions or intellectual disabilities. They're obviously much more able to integrate within society. They're able to engage in school. There's a really fun gym that integrates persons with Down syndrome and other disabilities with more neurotypical individuals. It's a great place to watch just kids kind of interact with all the kids regardless of their level of function. Developmental outcomes are also improved. While it's still typical that persons with Down syndrome will require some degree of support and supervision throughout the span of their life, you're seeing all sorts of different things about like a person who just graduated law school with Down syndrome, or people with Down syndrome entering the workforce, having a stable job, having a stable income, and potentially even living independently. These are all phenomenal gains that have been made, again, by virtue of medical advancement, better access to early services, the skill of our PT, OT, and speech therapy colleagues, and their overall experience with persons with Down syndrome. Now, I'm talking a lot about these really great things, but of course, the pessimist in me wants to talk, again, about some of the more doom and gloom stuff. So we talk about all of these remarkable gains, The purpose of this talk is really to talk about regression. So what is a regression? It's a term that describes a loss of previously acquired developmental skills in an individual. This can span every single developmental domain. So we're talking about activities of daily living like toileting, dressing yourself, eating independently, language. This can include things like a complete loss of words, or if you were never verbal to begin with and you communicated with an adaptive modality of communication, losing the ability to engage with that. Loss of motor function, so not being able to walk or run or ride a bike or sprint or things like that. And of course, social withdrawal or loss of social skills. This can be caused by a number of things, and I'll kind of go through all of the typical things we see in persons with Down syndrome and how Down syndrome regression disorder may be a more unique entity for a specific age group. Is it common? It's a little bit hard to say. We know that there's a number of conditions that are more likely to happen in persons with Down syndrome, that all of which can cause some kind of stepwise decline in overall developmental function, but it's really difficult to say. Back when I was in my fellowship, one of the common diagnoses we would get referred as the justification for us seeing a person with Down syndrome included late onset autism or early onset Alzheimer's disease, or just some kind of psychiatric disease not otherwise specified. And I'm hoping by the end of this grand rounds we'll kind of be able to distinguish why those things are probably not what's explaining this and why these patients need a little bit more of an aggressive workup and evaluation. That said, despite having seen a really ridiculous amount of patients with Down syndrome regression disorder during my fellowship, we do think that this is still pretty rare, affecting much less than even 1% of the persons with Down syndrome, and we think the age range is between 10 years of age until 30 years of age, give or take. There's a lot of different causes that can lead to a regression, and timing really matters. So regression just describes what is actually happening with the patient, what's changed about them. But the timing matters. So there can be situations where you have a regression that is overnight, where gone here today, gone tomorrow, or taking on the order of weeks. There can also be a kind of slower, more insidious type of regression. Really what I'm going to be talking about is the more acute and subacute onset of regression in persons with Down syndrome. Despite my pitch that it's going to be autoinflammatory in nature, there does seem to be a multifaceted nature to it. There's a whole bunch of different things at play here, and I don't think it would be feasible to say, aha, it's just this one thing, or it's just these two things. I think all of these bubbles here all play a role in the development of regression in persons with Down syndrome. So, types and timeline of regression in persons with Down syndrome. So as early as 3 months to 18 months of life, there's already a time point where persons with Down syndrome can get hit with something that can cause a regression, and that's epileptic regression. This is classically referred to as infantile spasms or West syndrome if you have the triad of clinical infantile spasms, Hips arrhythmia on the EEG, and developmental delays or regression. This typically only happens in this age group of 3 months to about 18 months of age. It's really unlikely to happen before, really unlikely to happen afterwards. What's unique about this is that persons with Down syndrome are kind of tied with tuberous sclerosis as being the most common genetic etiology of persons who have infantile spasms. So in your kiddos with Down syndrome, really be paying attention to the onset of infantile spasms. Outside the scope of this conversation, but just wanted to make that plug. Autistic regression. Now there are some neurodevelopmental experts who will hem and haw and say there's not any true regression that happens in autistic individuals. There are some people who will say there definitely is acute regression that can happen in autistic people. I tend to take it in the middle and say there can be some mild degree of regression, but it tends to be a slower, more insidious loss of some kind of language-related skills and social interaction skills. But typically this happens well before the age of 8 years of age if they're going to have onset of autism. Talk about this in a minute. Alzheimer's disease. Now, persons with Down syndrome are at a higher risk of developing Alzheimer's dementia compared to the neurotypical population, and really why that is the beta amyloid protein that is the precursor and kind of builds up to abundance in persons like us who develop Alzheimer's later in life. That made it seem doom and gloom that we're all going to develop autism. That's not the case, is present on chromosome 21. And so again, like we talked about with the inflammatory milieu having upregulation of interferons, you can have increased production of beta amyloid, therefore leading to a higher incidence of Alzheimer's and an earlier age of onset of said Alzheimer's disease. But if you think of any person who has Alzheimer's from back in our med school days and my adult neurology days, it tends to be a very slow and insidious course. And then, of course, there's systemic diseases, right? So hypothyroidism, celiac disease, arthropathies, vasculitis, all those types of things can also cause this, but I'm going to show why this particular condition is fairly unique as it pertains to all these different disorders. So now we're going to get into the meat and potatoes of this, is the clinical manifestations. These cue cards over here are actually written by one of our patients who developed a significant loss of language and who essentially developed a compulsion where she just constantly was writing things down. And one of the things that she had written down in one of her cue cards, fairly repetitively, which is the scary part, brain ferg, which I assume or we think means brain fog, call 911, help, call, and obviously she had some problems with writing 911 again, and then I hurt I. Unsure if she meant her eyes or if she meant just herself as a person, but these are the types of things that we're going to kind of describe here. So what are some of the symptoms that we see in Down syndrome regression disorder? The symptoms are typically sudden and they're typically dramatic. These are people with Down syndrome who are otherwise high to medium functioning individuals who are able to do a lot of their own activities of daily living by themselves, who essentially lose those functions within days to weeks. Symptoms can be preceded by a stressor or infection in up to about 50% of cases, and the typical age range is about 10 to 30 years. And I'm going to show later on how this is too old for autism and too young for Alzheimer's dementia. Now, I want to make a quick side note here. Notice the sudden, dramatic nature being preceded by a stressor or infection, how that seems to correlate a little bit with another known neuroinflammatory disease of autoimmune encephalitis. We're kind of positing here that Down syndrome regression disorder is a unique form of autoimmune encephalitis towards persons with Down syndrome. The clinical features can include things like insomnia, a complete dysregulation of the circadian rhythm. Patients just essentially stay up all night, rocking in their bed, refusing to engage with the outside world or try to go to sleep. Catatonia, and I'll show some videos of this, but it's essentially just this significant stiffness and inability to initiate movements. Along with this catatonia includes bradykinesia, or just this slow, lurching type of movements. There's often psychosis with agitation and delusions and hallucinations. There's a near complete loss of language or previous communication skills. And typically patients almost seem like they have a new and severe autistic phenotype where they just socially withdraw, refuse to engage with people that they consider their best friends, or seem even unlikely to recognize the people around them. Interestingly, when we were first characterizing this condition, you look back at the 1950s and 60s and 70s at institutionalized persons with Down syndrome, and every so often you'll see a case report of a person with Down syndrome who was talking, who was fairly capable and functional, had a milder phenotype, and then one day just kind of stopped, seemed to develop some kind of catatonia, Parkinson's-like feature, and they said, well, this is just something that happens in Down syndrome. Have a nice day. And that's still something that we see even to this day, but this is something we suspect has been present for decades and decades, but is only now being recognized as something that is both a identifiable disease and also, I hope to show, a treatable disease. I have a couple of videos here to show the catatonia that we see in persons with Down syndrome. When you think of catatonia, most people consider, schizophrenia, primary psychiatric disorders only. And yet, over the last few decades, we found that there is actually some kind of immune-related response that can often precipitate the onset of catatonia. That's why it's such a core feature of diseases like anti-NMDA receptor encephalitis, as well as Down syndrome regression disorder. This is just an example of waxy rigidity, the phenomenon where you put a patient with catatonia in some kind of positioning, and they'll just maintain that position because they have a lack of ability to initiate volitional movement. My recommendation typically is to put them in something like an uncomfortable position. My rock out position tends to be kind of a preferred one because this is kind of a non-natural position. If you just put someone like this, they might be like, why are you putting my arm there? Well, I guess I'll just keep it there. But if you put them in something a little bit more uncomfortable and they maintain it, it's kind of proof of the catatonia. This is another video showing just, again, the waxy rigidity.
Can we turn around, Stephen?
And we're kind of prompting him to go back to the room. But notice how slow he's moving. Think of a late-stage Parkinson's patient. I know I'm talking to the wrong crowd when I talk to pediatrics folks about Parkinson's, but think from your medical school days of those late-stage Parkinson's patients who just seemed to struggle to do something as simple as take a few steps forward. That young man, by the way, loved to ride his bike before he had onset of these symptoms. He obviously can no longer ride his bike, or could. He now can again, but could no longer ride his bike. Another core feature is speech, sleep, and socialization. I also love alliteration, by the way. There's a stark loss of contrast in persons with Down syndrome. They will be talkative, engaging, maybe able to read. One of our patients with DSRD loved to be in the theater, so she would play in plays and things like that. Suddenly, she just could not remember even the most basic of lines that she'd rehearsed hundreds of times before. Most patients will become completely mute. There's also a total dysregulation of the sleep cycle. Parents will say that, I thought I put my child to sleep, and I'll just watch them walking around and wandering the halls, completely unable to recognize what's going on around them. And there's also a stark withdrawal and internalization. Patients with DSRD go from being like, I have a best friend, their name is Mary, and I love to have conversations with them on the phone every single day, to no, not even wanting to recognize or engage the people that they typically loved to be around and play with. And if you think of a person with Down syndrome, think of often, at least when I'm able to imagine a person with Down syndrome, they're often very happy, they're overly social, which is what makes diagnosing autism very difficult in them. And so you can imagine this stark contrast of overly social and engaging individuals to completely withdrawn. There's often also a disassociation that tends to happen. Patients can kind of seem apathetic or just disinterested in the outside world. It's almost like they're trapped inside their own mind and they can't really be a part of the world that they were once a part of. I like to take notes of things that families tell me. I think they kind of are pretty impactful. And so I wanted to include here a few lines that we've gotten from some of our families over the last years. Things like, it's like someone has replaced my daughter with someone else. She's just not the same child anymore. I have a ghost who lives in our home now. He's just a shell of himself. It's like someone took the happiness center out of his brain. And for those of you who've seen a lot of persons with autoimmune encephalitis, this is a lot of the same type of language that we hear from persons who will come in and say, this is not my child. Whatever's been going on with my kid over the last few weeks, this is not my child. And a similar type of phenomenon seems to be happening in a small subset of our patients with Down syndrome. This on the right-hand side you'll see is a whole bunch of written language. This patient completely lost her ability to speak, but developed a compulsion of writing in her notebook. She would have stacks and stacks and stacks of these binders in her room, just full of very similar language. And I just want to highlight a few things here. You'll notice as you get a bit halfway down, the references to Jesus, Jesus, love, sister, journey of the stars, and that makes fine love, not my love. All those types of perseverations are present in all of her notebooks, and you almost see this kind of hyper-religiosity that happened in a child who, while they would engage in church services, from the parents' perspective, was not an overly religious individual at the time. Now, on the other end of that tunnel, I have some testimonials of patients that I've written down that had actually received treatment for Down syndrome regression disorder, and they would say things like, I'm coming out of a nuclear reactor. And one patient even said, my computer is on again, referencing his brain, of course. So question is, could this just be late-stage autism, right? Like, we know that some kids with Down syndrome can develop autism a little bit later because they're very social, they're very happy, they're very outgoing. It's hard to tell if they have autistic features because I've seen a number of children who are diagnosed with autism and Down syndrome who are still the first ones to come and get that high five and the last one to get out of the clinic room. While it's highly prevalent in persons with Down syndrome, it's observed to be about a third of patients. The onset is typically slow. Acute regression's been observed in persons with autism, but it's not the rule, so to speak. Again, it typically should not happen newly in persons who are over the age of 8 or 10 years of age. You should have some kind of history to suggest, hey, they had some autistic features like ritualistic behavior, habitualization, difficulty with changing of routine and things like that. The really important point also being there's no test for autism. I can't just get a blood test and say, aha, this child with Down syndrome who regressed completely just has autism. For those interested, and I think the PowerPoints will be sent out later, there's a list on this left-hand side about some of the unique differences between autism and Down syndrome. I won't go into it because it's already going to be a long presentation, but basically to say, if you have autism in a person with Down syndrome, they should kind of have those features, even subtly, way before the age of 10. Now, we do know that persons with autism, especially if they haven't received early interventions like ABA therapy and things like that, particularly our boys, when they hit puberty, they can sometimes have a bit of a regression of sorts where they become more aggressive, they become more combative, their behavior completely takes a left turn. But even that is not the same as a complete internalization or withdrawal, which we see in this condition. Is it just early onset Alzheimer's? That's a bit of a hard push. We saw this diagnosis a whole lot in 18-year-olds, 20-year-olds, 22-year-olds, and I kind of put here on the left-hand side a bit of an outline as to what typically happens. There's beta amyloid accumulation. as early as 15 years of age, and that typically continues into your 30s and 40s. There's tangle accumulation, which then leads to the actual onset of the features we think. That typically happens between 30 and 40, and the actual clinical symptoms don't happen until your mid-40s to late 50s, right? But again, I want to stress, this is slow. There's not a lot of people with Alzheimer's who are perfectly functioning persons at a college and university who then just become, demented. That's not what happens. It's typically a slow, steady, insidious decline. And also, very importantly, persons with Alzheimer's rarely have frank neurologic complications early on in their course. While they can develop those things over time, early on, the main issue is mild cognitive dysfunction. That's not what's happening here. Are there other things that could do it? Sure. Celiac disease is known to cause some developmental dysregulation. Hypothyroidism, of course, if untreated and unidentified in persons who, whether they have Down syndrome or not, can lead to significant loss of skills. Epileptic encephalopathies can happen rarely in people who are teenage-yeared. Type 1 diabetes, if you truly are undiagnosed and just have chronically dysregulated glucose, I suppose you could have some periods of hyper and hypoglycemia. Arthritis can lead to some dysfunction from a motor standpoint. Vasculitis, yes, but all of these typically are slower. There's not anything that just, bam, causes some kind of significant regression. What about primary psychiatric disease? Definitely, right? Schizophrenia. A little hard to say. So there's not a lot of studies in the first place looking at the psychiatric phenotype of persons with Down syndrome. That's a unique kind of frontier that might need to be investigated in the coming years. But when you look at a comparison of persons with Down syndrome compared to persons with intellectual disability, notice the kind of breakdown in what's seen there. You'll see a 35% of the population of those persons with Down syndrome studied in this cohort have otherwise unspecified psychosis of some kind. It's a little bit odd. Right? And we already talked about how with DSRD there is a psychosis type of feature there, whereas in persons with intellectual disabilities that's a much less used diagnosis. By default, psychiatric diseases should not have frank discernible neurologic abnormalities. You can have some things here and there, but the onset of sleep dysregulation, catatonia, bradykinesia, significant loss of language, that should not be seen in purely primary psychiatric diseases. And furthermore, psychiatric diseases tend to have a slower onset of symptoms. I also just want to make a side note that persons with intellectual disability typically have difficulty with discerning real versus pretend or imaginary, and the concept of self-talk can sometimes be misinterpreted as a psychiatric disorder, may not actually be. So to kind of summarize the differentiating factors here, there's some unique things going on here. In terms of the age, these symptoms tend to come on in between 10 to 30 years of age. Typically after the diagnosis of autism or epileptic encephalopathies most commonly occur, but before the onset of Alzheimer's dementia. There's typically some kind of provoking factor, a stressor or some kind of infection. And the speed of onset tends to be extremely rapid, on the order of days to weeks. The symptoms primarily kind of cluster around mutism, bradykinesia, catatonia, and new autistic-like features. Classically, we used to just kind of get some tests here and there, get some blood work on patients who regress with Down syndrome, maybe get some imaging, maybe do an EEG if we worried about seizures. But at CHLA, the question was, well, would we do anything differently if this person didn't have Down syndrome and had this exact same clinical feature? We would. We typically will admit a patient, get MRI, EEG, LP, all these tests all at once in a short period of time because we're like, why did this person suddenly have such a stark regression? So we took that same approach in persons with Down syndrome who we suspected having this condition. So we would get a whole bunch of stuff. The blood work, I won't go into every single test that we get. It's really just to identify a lot of the differential diagnoses that can somewhat look like Down syndrome regression disorder. MRI is extremely helpful because obviously it gives us a window into what their brain looks like, whether there's some signal abnormalities or other features that suggest inflammation. EEG is kind of just a marker of overall general neurophysiologic function, and LP can be helpful because it's as close as we can get to a biopsy. Because we use this as we use all these tests, it's primarily because there is no one single test to diagnose Down syndrome regression disorder. We've developed a clinical criteria for it, but that primarily makes it a diagnosis of exclusion, where we have to rule out all of the other possible things and make a case for why this is most likely Down syndrome regression disorder. The reason that workup is so important is we've had a number of patients referred who, by process of our workup, we've identified an alternative etiology. In one patient, they actually ended up having moya-moya syndrome and had stepwise neurologic decline over the span of a few months. In another patient, they had primary CNS vasculitis, where again, they had a stepwise decline of neurologic function over a period of months. We had one patient with undiagnosed hypothyroidism and one patient with undiagnosed celiac disease. Actually, many patients with undiagnosed hypothyroidism for some reason. Check the thyroid in persons with Down syndrome. Now, neurodiagnostic study abnormality hit rate, it's pretty variable, but we would see some kind of abnormality in up to 40% of the cases that we would see. That number is higher now that we have a larger population that we've studied. This is an example of a control patient with Down syndrome where we got an MRI of the brain. And this is something that we notice in persons with Down syndrome who we think have Down syndrome regression disorder. This is an SWI sequence, and what this is kind of a fancier, better quality GRE. What we're seeing here, and I'm going to highlight it in red here, is early mineralization of the basal ganglia. This happens in up to 30% of individuals that we've studied who have ultimately what we think is Down syndrome regression disorder, compared to 8% in age-matched controls, with a pretty high N of 233, I will add. This finding in and of itself is one of the most highly predictive features of subsequent immunotherapy responsivity. So we're really looking for this finding amongst persons who we suspect as having Down syndrome regression disorder. So the question is this just red herring? Is this just something that we happen to find on accident here? Well, I want to draw attention to a notably also very rare condition called Aicardi-Goutieres syndrome. This is a type 1 interferonopathy. And if you can remember interferon, remember that we talked about in persons with Down syndrome having upregulation of the amount of interferon activity in their body. In Aicardi-Goutieres patients, notice what we see here. This is their MRI. They have also significant early mineralization of the basal ganglia, as well as other parts of their body. These patients typically have rather significant loss of brain function over a short period of time. But I just want to draw that correlation between persons who we suspect have DSRD and persons with Aicardi-Goutieres. Notice the similarity of that early mineralization of the basal ganglia. There can also be change over time to kind of further prove the point that this may not just be some incidental finding. This was a patient who got referred to us after, I think, 5 or so years of having symptoms of DSRD. They had early and mild features of mineralization early on, whereas later, after we obtained that scan 4 years after the fact, that area of mineralization is larger. So is this just kind of the perfect storm? There's a genetic predisposition to immune dysregulation. There's some kind of stressor or infection or trigger that leads to a significant inflammatory cascade and dysregulation and propagation. There's some kind of neuropsychiatric disease that presents and some multi-system dysregulation. So here's the other big question. Why? Why are we looking into this? Well, there's got to be some kind of treatment, and there is. So there's not a single treatment, but we've kind of come up with a multifactorial set of treatment approaches to try to manage Down syndrome regression disorder. Obviously, there's a whole lot of psychiatric disease on top of their neurologic disease and the immune dysregulation, and so we focus on multiple areas. The focus includes things like antidepressants and antipsychotics to manage compulsive behavior, ritualisticness, psychosis, and things like that. I will talk briefly about electroconvulsive therapy. We don't ever encourage it amongst our families who have kiddos with Down syndrome, but many families will sort of, because they're not getting answers from their healthcare teams, will often go to places that provide electroconvulsive therapy for persons with Down syndrome and will actually attempt to treat them with it. We use, obviously, immunotherapy quite aggressively, cholinergic agents to help with some of the cognitive dysfunction, and benzodiazepines primarily to help with the catatonia. But the question is, do any of these work? Some of the benzodiazepines certainly help with catatonia, but I really want to draw attention over here to the immunotherapy response. The vast majority of our patients, when we tried very clearly to stick to our diagnostic criteria and those we highly suspected as having DSRD, responded to some kind of immune therapy. And the biggest response was not in steroids, as one would classically expect for immune therapy, but it was in IVIG. And it's notable that persons who had a neurodiagnostic abnormality, I want to note that 92% responsivity, right? Compared to those who had otherwise normal studies who still had a response rate of 82%. It's a very important clue that, hey, there's something that seems to be going on here in response to immune therapy. But obviously the question is, well, what's the endpoint, right? We don't just kind of indefinitely put patients on immune therapy unless they have a condition that warrants them being on indefinite immune therapy, but we don't think this is that condition per se. It's unknown, though. We're trying to learn from other neuropsychiatric and immunologic disorders. I made a PANDA reference for those who are in the know, but an endpoint was needed. And so we tried to create some kind of endpoint during my fellowship year. And it happened to be, of course, that the majority of our patients were being weaned off in the middle of my fellowship year, which was a fun thing to go through. But some interesting things came of that. So in the first 82 patients that we treated with IVIG, we weaned them after about 9 to 12 months. It was a slow wean. And they fell into two camps. Half of the patients had no recurrence of disease. They made their progress, they made their improvement, they got very close to their premorbid baseline, and they continued along despite discontinuation of IVIG. In the other 50%, unfortunately, they had regression again of their symptoms despite weaning. And you're probably going to say, all right, but how did you just say like, oh, they're better, cool, IVIG works? We tried to use as many objective markers of improvement as we could. So we did things like a 25-foot walk, Bush-Francis scale for catatonia evaluation, global clinical global impression scale, and neuropsychiatric inventory. And as you can see, in the persons who had relapse, that's the dotted lines, they, like the no relapse patients, improved over time. But once we weaned them off, the ones who had relapse obviously worsened in all of these domains, whereas the patients with no relapse continued to either make improvements or remain clinically stable. An interesting trend started to be noticed. Of the patients who relapsed, more than not of them had some kind of neurodiagnostic abnormality, whereas the persons who did not relapse otherwise had a normal diagnostic workup. It's an interesting thing to note. Some unintended benefits. There were no complications in our cohort of patients who received IVIG or adverse effects, aside from obviously having an IV placed, which in a person who is psychotic and agitated, who you've disinhibited by benzodiazepines, can be difficult to hold down for an IV. But in 34 individuals who had some kind of autoimmune skin condition, the majority of them had some kind of improvement of that. It's kind of a fun fact. And the 4 patients of ours who ended up having a history of rheumatism of some kind of arthropathy, pain and joint swelling improved in all of those patients. This was a young lady of ours with DSRD who had significant alopecia. This is after 2 treatments with IVIG. Wish I had that same effect. This is a young man who had eczema before immunotherapy, who obviously had DSRD. After 21 days of treatment, notice how clear that has become. The prognosis is actually quite good. We unfortunately are still working on getting patients fully back to their premorbid baseline, but these are some 2 examples of patients of ours who've made drastic improvements. On the right here is a young lady who was a Paralympic athlete, who obviously by virtue of onset of her disease could not participate in any kind of meaningful physical activity, but after getting her treatment for about 6 months, she's now working on getting back into the Paralympics and her physical activity. This young lady on the right is that first young lady who I mentioned who was writing all of those compulsive, hyper-religious statements. She still cannot fully speak and primarily communicates with her language, but she's able to make fun jokes. I drew an ice cream cone, and she called it a poop, which I think was cute. But obviously, I can talk at length about DSRD, the clinical features, how we think the treatment works, and all that jazz. But I think this video created by one of our families, who I have permission to share, shows kind of provides the best kind of image of what this condition is.
Go away. I am now going to go to today.
Yeah. Are you ready for the rest of your smoothie? Huh? Are you? Friday. Happy Friday. It's okay.
This is bad. I mean, the way you can come and the way say it, the way calm down.
Yes.
I mean, so wet.
Sweaty?
So wetty.
Sweaty. Go take a shower.
Need to get shower.
Yeah.
Need to can't hear you say it.
Can't hear you say it? Okay, Kristen, can you go take a shower?
So that young lady was one of our earlier patients with DSRD. She'd had symptoms for many years before we started her back on IVIG. Prior to, she was working on reading, as you saw in that video early on, and afterwards she went from being this bright, happy, engaging lady to basically just kind of huddled in a corner, struggling to do things like eat, was not really able to speak, and that was about, I think, can't remember if it was 4 months or 6 months after IVIG, but she's regaining a lot of her language skills, engaging more in clinic. She actually tried to lead a lot of our clinical engagements whenever she would come for follow-up visits. Questions?
All right, thank you so much. That was a wonderful presentation, very interesting, and I think for me anyway, a lot of really new information. So thank you for that. That was great. Remember, for questions, you can put your question in the chat, and I will ask it for you. If you're in the audience here, I'm able to pass out the microphone, and you can ask your question in person. I have a question related to, I guess I wouldn't call it prevention, but kind of early diagnosis, because, you know, I was thinking as you were speaking that, you know, all patients with trisomy 21 get sick, they all get colds, they don't all develop this. And I wonder if you've had any experience of recognizing a patient kind of in the early part of the disease, and what that looked like, and then also if there were any laboratory clues that this might develop.
It's a great question. So we're still looking for some kind of biomarker that we can more reasonably obtain. You can't really justify getting an LP on every single person with Down syndrome who might be acting a little bit differently after they've been sick. But we're trying to find some kind of blood test that might be a clue. We haven't found one yet. We have some more recent data looking at CSF proteomics and inflammatory omics. A lot of omics lately. I can never remember what the actual omic words are anymore. But no, there's not some kind of pre-presentation biomarker. We have caught this early in a number of patients because we've been increasing awareness of this condition. Treatment obviously is much more effective when we identify it early. There's a study that we're going to consider where persons with Aicardi Gutierrez are kind of treated at birth essentially with a JAK kinase inhibitor. We're looking to do a very similar thing in persons with Down syndrome from basically the get-go, because we suspect that there might actually be some kind of interferonopathy associated with Down syndrome. That's not just, oh, they have trisomy 21, but in fact, they're kind of like Aicardi Gutierrez where they have an interferonopathy. Sorry for the long-winded response.
Right, Dr. Parsa.
Thank you so much. This is fascinating, especially because you're speaking my language, you know, in terms of the autoinflammatory disease that's seen. I think what's really interesting is that, you know, I take care of patients with trisomy 21 who have raging arthritis. And as you probably seen, those that are watching the video, they're hypermobile. So the delay in diagnosis is profound because they're at baseline hypermobile, and then they're coming in because their feet aren't growing because they have raging arthritis. I don't know if you're up to date on the arthritis and trisomy 21 literature, but we're really pushing more for JAK inhibitors now because tofacitinib or Xeljanz is already FDA approved for rheumatoid arthritis and for juvenile arthritis. And so traditionally we were just going our usual route of Humira, tumor necrosis factor inhibitors, and now we're actually going more JAK inhibitors. So just learning about the disease, you can target it, which is amazing. And I think it was my patient with the moya moya that we thought it was the regression disorder.
Yep.
And then had that, and she was hospitalized for months, but she's doing better.
Yep. Yes, she is. Yeah, they can be strikingly similar. It's really hard to be able to tell. I've been surprised a number of times, like, this is going to be DSRD, and it's some kind of like, oh, okay, cool. No, it wasn't that.
Yeah. Thank you for sharing your experiences there. I mean, I think Sia Chile and Dr. Santoro and you being a part of it really has elevated our knowledge about this. You know, this really, I didn't learn about this when I was in training. That was not that long ago, but
I will add, for anyone who's curious, those emails down below, this is my email, mkhoshnood@sbch.org. If you have questions about patients, regardless of their age, if you want to reach out about them, either I can see them in clinic or make the determination like, hey, they actually need a more rapid workup or whatever have you, send them over to Dr. Santoro. But I've also included Dr. Santoro and his research cohort. They're constantly doing trials and studies and things like that. So if you want to reach out to them directly as well, you're more than welcome to.
Thank you so much. I was wondering if you could elaborate a little more on the difference between the two cohorts, the relapse versus no relapse. And you were saying that the relapsed patients were more likely to have actual like abnormality on the neurodiagnostics. So were all patients without an alternate diagnosis treated, and then it was just ones with some sort of ill-defined but present neuroabnormality more likely to have the relapse?
Kind of, yeah. So we created a clinical criteria to try to more accurately diagnose this. We didn't want to just say, oh, we did a whole bunch of workup, we're just going to say you're DSRD. We tried to be pretty strict about you have to meet a certain number of our criteria, which was, I think, 4 out of 6. It's a very long clinical criteria. I can send it if anyone's interested. But we tried to be very fixated on you got to meet this clinical criteria before we can do a trial of IVIG or immune therapy in general. So we really tried to stick with that because obviously the neurodiagnostic maladies are not 100% of the patients that we saw, either because we caught them super early or because we just haven't found the right study yet. We're really actively looking at CSF to see if there's some kind of unique biomarker for this because of that. But in those patients who had a relapse, there was some kind of abnormality, and the most common abnormality was the neuroimaging abnormality, that early mineralization. Some of the other abnormalities included things like oligoclonal bands in the central nervous system, mild pleocytosis, elevated protein, things like that. EEG, while it was there was still a pretty equal number of patients with an abnormal EEG who didn't relapse compared to those who did relapse. But the MRI findings were really notably the ones that had that higher incidence of having a relapse.
Thank you. And then I have one other question, which is a little bit more about the sort of like early diagnosis and access. Like, what are the ways that you've been sort of spreading the word to all of the community pediatricians and community folks who are seeing patients early on and trying to increase awareness of this?
Yeah, so Dr. Santoro and I have been going on lectures for the past couple of years. He's at the tail end of my fellowship. He sent me on a few lectures out, in places like Las Vegas, up in Northern California, and things like that. So it's really just a lot of family awareness, believe it or not, and then also physician awareness by going to like conferences and stuff like that. We found that when we tell families about it, it's actually a lot more likely that they'll just kind of be like, hey, something's off with my kid. Do you think we should do this? And then we're able to connect with their pediatrician and be like, hey, here are our thoughts. You let us know if you think this is a reasonable type of thing. And so it's a lot of like open door access. Like you can just reach out to us and we'll say like, yeah, this is suspicious, or no, it's not suspicious. And we kind of take that approach with it.
There's a question online about IVIG, and maybe you could just briefly, I know you had this on a slide, but maybe you could just briefly talk about kind of what the regimen looks like. These are all coming into an infusion center and getting IVIG. The question is related to, do you have a difficult time getting authorization for IVIG? And if so, is there literature that supports use of IVIG with this patient population?
We do not. We had, back in my fellowship year, we had like a 97% approval rating. And the few times that it wasn't approved, we would basically do a peer-to-peer and they'd be like, okay, there you go. Have a nice day. We had no difficulty getting this approved. And a big part of that is there's been a lot of literature. If you just PubMeded Down syndrome regression disorder and Santoro, there's probably like 30 something articles that all basically prove like this is safe, this is effective, here's proof and data and all this kind of other stuff about it. In fact, later this year, if we can get our ducks in a row, there's going to be another publication proving the efficacy of IVIG over benzodiazepines in isolation for the treatment of this condition. So we've really not had any difficulty with it, but obviously like we have very specific language in our notes that we use to ensure that we get that approval.
Okay, well, great. Thank you again. This is a wonderful presentation, a wonderful topic. We're really appreciative of this. So thanks again for presenting. And I hope everybody has a great rest of your day. Remember, next month's Grand Rounds is going to go back to the second Tuesday of the month. Okay, thank you.
Thank you all.